Can you take the occasional opioid on with an acute new injury on LDN? Whew. So above 1 milligram, you can see blocking. So an occasional, we call it PRN, so as needed opioids. So you twist your elbow, you're playing hockey, and you're just like, oh, I need something. I've got some tramadol just in case, or I've got an acute knee issue. And so I take the very rare Tylenol 3 or oxycodone. We've seen this, and we just see that it's less effective, especially if you're separating the dose of your opioid from your naltrexone. The half-life of naltrexone, 4 to 6 hours, we know that. So 5 half-lives around 30 hours, we know it's almost completely out of your system. That's why we do the minimum once daily dosing. But if you're taking your naltrexone and you know you've had an injury, if you can switch it to the morning dose and you take your opioid at night, then you've got that separation. They'll still continue to work. May not be as effective, but it'll still work. Now, the flip side is if you need it in the day because you have a physically active job and you may need the occasional tramadol or T3 or a Percocet to get you through because your activity is so much and your hip is blowing up and you're just like, oh God, I'm going to cry. Take your naltrexone at night. There you go. It will still work. You're not gonna have a negative repercussion of that. For chronic dosing of opioids, and now I'm crossing into a non-question at this point, anything above 1 milligram may completely block pain control, which may take a couple of days to get back. And that's a chronic consistent. So that might be one Tylenol 3 times a day, 4 times a day, consistently, because at some point when you get above 1 milligram, you have more naltrexone and it's going to last and it's going to block. We don't know the absolute dose in any patient. If you have high biotransformance and low clearance, you might hit it at 1. If you have a high transformance and a high clearance, you might hit it at 1.5. I don't know. But I do know when you go into a real pain hole, you're going to be angry about it, and you're probably not going to trust anyone with your naltrexone dosing anymore, and you're going to abandon it. Again, dose is too high. We can still effectively treat a lot of the background immunological modulatory response at that 1 milligram of naltrexone. 1 milligram is still 1 milligram more than you're getting, and we know that it works. We know we're still getting a response. It just might take a longer time to see the outcome. But we're also actually seeing with that 1 milligram dose changes in behavior pattern, and we break opioid hypersensitivity. It's still there. It's still in that range. And it's called opioid-induced hyperalgesia. And we can also see breaks in dependence and habituation and that reward response. So we stop breaking that need, so to speak. And so some people start skipping doses, even at 1 milligram of naltrexone in their chronic uses. Now, anything above a high dose, and these are the patients, and I'm talking to providers and professionals. And as a patient, if you are not sure if you're in the high dose opioid, ask. Just ask the question. High dose opioid patients, much more caution, much lower initiation doses. And you have to be much more sensitive to their response. If these patients start talking about like, yeah, I'm feeling more pain, your dose is getting a little high of your low dose naltrexone. I start them at 0.1 milligrams and titrate very cautiously. Narcotic collapse is a true thing, and we never want to see any patient get anywhere close to that. Number one, can be very complicated and very complex for patient care. Number two, we don't want to cause that patient any harm or any untoward negative response. Number three, that patient will never trust you again. And that is not a relationship you should ever be treading on. This is a healthcare professional relationship. We, first and foremost, we want to help patients, not cause problems. And loss of patient trust, they're just going to, you're never going to have success in getting them off of opioids in the future or helping them with any of your recommendations. So caution, caution, caution. And if you don't know if you're a high dose opioid patient, ask a pharmacist. They'll tell you. I'll tell you.